So should I start then? It's indeed a great pleasure for me to introduce to you uh, Professor Chitra Prasad, who's a professor at the Department of Pediatrics, Section of Genetics and Metabolism, and Director of Metabolic Unit at the Western University, London, Ontario, Canada, since 2003. She's also the Director of Newborn Screening since 2006. She has subspecialized in clinical genetics with the certification in both clinical genetics and biochemical genetics. Before coming to London, Dr. Prasad held faculty positions in medical genetics at the Memorial University of Newfoundland, St. John's, and University of Manitoba, Winnipeg. Dr. Prasad has published many articles and book chapters on a variety of genetics and metabolic syndromes and their pathogenesis. And her clinical interests include dysmorphology, pathogenesis of clinical genetic syndromes, and inborn errors of metabolism. And since these days we have this new language of genetics, which is being used in each and every disease, we thought it would be most appropriate to have a lecturer of her eminence to deliver this lecture today to all the audience of PGI Chandigarh. And I'm really happy to inform you that Dr. Chitra actually is one of us, and she has done her MD residency in pediatrics from PGI Chandigarh. Dr. Chitra, we are very eager to hear you. Please come online.
So thank you very much, Meenu, and it's indeed a pleasure and honor to be invited, and thanks so much for doing telemedicine. So even though we are so far away, thousands and thousands of miles, we can still be together. So I am going to do this lecture on a little bit of approach and just take you through a couple of cases and hopefully talk a little bit about therapies. So we'll see how much we can accomplish, and you can use the chat function or let me know the questions at the end. Okay, so this is a very exciting field and all of us are learning everything. So everybody is going to stay a student in this field of medicine. And as Meenu said, it is impacting every specialty of medicine. So my objectives are to bring to you the power of observation, and that is the key power in genetic assessment and dysmorphology. To remember about genes and environment. So say if it's maternal nutrition or exposure to toxins like fetal alcohol syndrome, to think about chromosomal disorders and what are the indications for microarray. So chromosomal microarray has become the front line for investigating patients with developmental delay, children or adults. Then thinking about single gene disorders, giving you examples of genetic syndromes associated with developmental delay, dysmorphic features. How do we make the diagnosis? Sometimes we are very clear, we can go straight to the single gene sequencing. We also use a lot of panels, NGS, whole exome sequencing and whole genome sequencing, which is more in research phase, although it's being used in some labs clinically. And then therapies. So I deal a lot with metabolic disorders where we have a lot of therapies, but now even in genetic disorders, we are coming across treatment modalities. Why do we want to make a diagnosis? Parents always want to know why this happened. Will it happen again? And as you know, the family structure, even in India, people are not having 8 or 9 children, so Everybody wants healthy children. And then what to expect with this diagnosis? Is there a possibility of therapeutic intervention? Can we do surveillance for known complications and how to maximize the potential of that child? And then, of course, prenatal and pre-implantation genetic diagnosis in certain scenarios. So this is a very basic history taking, which, I usually do this, and all of you are familiar. Age of the mother in pregnancy, illness, medications, hypertension, what was the fluid like, is there any problem with the movements? That's a good thing to ask. Also, history of hiccups. Sometimes you get a history of seizures in the newborn, and you go back and ask, and the mother will say, yes, I did experience hiccups. And is this pregnancy by IVF, assisted technology, or naturally conceived? What was the delivery like? All the details of delivery. What is the neonatal history, feeding anomalies, developmental, past medical history, review of systems. So in genetics, we basically take care of everything. It's not just one system. So we are looking at the whole baby. Prenatal history, which is suggestive of genetic disorders. So you can see over here a child with Down syndrome and a child with achondroplasia. And you can see the excess nuchal fold thickness here. So advanced maternal age is associated with Down syndrome, and advanced paternal age can be associated with achondroplasia. We can pick up congenital anomalies on ultrasound, and it has become a very important means to detect anomalies. Abnormal maternal serum screening, and it's different in different places. In our center, we are using NIPT, non-invasive testing, as well as first trimester screening. This is just about fetal alcohol syndrome, which you may not see as much in India, but in our Aboriginal population here, there's a lot of alcohol, and it's a toxin, and it can affect facial features, growth, as well as neurobehavioral problems for the baby. Development is very essential. So we all need to be very careful about our developmental assessments when we are seeing children with genetic disorders. So you need to know the normal development so that you can pick out what is abnormal. Family history is extremely important. And this is something that everywhere people forget. And I think we lose a lot of clues if we do not take a good family history. So especially history of multiple miscarriages for chromosomal imbalances, translocation, like is shown over here, reciprocal translocation and Robertsonian translocation. You will have a history of multiple miscarriages. Developmental delays, consanguinity is very important. Now, as you know, the world has become a village. So in Canada, in the place where I am in London, Ontario, we have many people from the Middle Eastern population. And there is a lot of consanguinity. And I remember even in Punjab and especially in the South India, there is a lot of consanguinity. So ethnic background is important. Certain disorders are common in certain populations. What do you need to look for an exam on a child or adult? So if suppose there is intellectual disability, it could be non-syndromic, where there are no major facial features, but there are definitely, we can do a gene panel and come up with some of the genes which are mainly being expressed in the brain. Syndromic means it is running together. It's a Greek word, and there are dysmorphic features, abnormal growth, and congenital anomalies. As you can see over here, this is the kabuki makeup syndrome. It's called kabuki syndrome. They look very much like the Japanese art people with the eyes. And this is the lateral third of the eye. There is, you can see how it's elongated. The ears are a bit prominent. Nose is a bit small. And this is the lateral third of the eyebrows is deficient. So this is kabuki syndrome. So you can actually recognize by seeing them. And then, of course, can confirm by genetic diagnosis. So basis of dysmorphology, I like this quote by Dr. Donai: no branch of medicine affords more opportunity for diagnosis of rare disorders than clinical genetics. So right now we are not discussing the common genetic predispositions or polymorphism, say in hypertension, diabetes, or polygenic disorders. What we are talking about is more of the rare forms of conditions where we know that there is a genetic etiology. So tools in dysmorphology are very simple. You need to be able to measure. And this is a nice book by Dr. Judith Hall, where they have done all the different parameters and centiles for all the measurements. And it's there in the Smith's textbook of dysmorphology as well. So never ever forget the growth, as we know. And you can see over here these two siblings and how the growth, the height is definitely low, and you can think about a skeletal dysplasia. Similarly, head circumference is very important. So just showing some pictures. So this is macrocephaly and microcephaly. Looking at the ears very carefully. So you see this is a crumpled ear. This is a cupped ear, and they can be associated with different syndromes. This is microtia, and this is post-auricular tags. So ears are important to assess. And if you draw a line from the lateral eye, so it should be 1/3 on top. And so you need to know if it's a low set on posteriorly rotated ears. This is mid-face hypoplasia, Treacher-Collins-like spectrum. And this is taken from a movie which became quite famous with this boy who had Treacher-Collins-like syndrome. And you see again, very abnormal ears and very small jaw and receded jaw in this spectrum of disorder. This is prognathism. So here it's receded and here it's prominent, the jaw. So looking at the face very carefully and the rest of the body very carefully. So when I see a patient for the first time, I always make sure that I have undressed them appropriately and seen their skin and all the findings, because you can miss a lot of findings otherwise. This is a child's mouth. You can see the cleft palate. You can see the high arch palate here associated with a lot of connective tissue diseases. And here you see the bifoot uvula, which is associated with conditions like DiGeorge syndrome or velocardiofacial syndrome. So again, examination of the mouth is very important. Here you're seeing webbed neck, which can be seen with Noonan syndrome and Turner syndrome. You see here polydactyly, clinodactyly, which is the fifth finger being bent, and syndactyly. So syndactyly meaning there is the two fingers are fused. Syndactyly of the two, second and third toe can be associated with Smith-Lemli-Opitz syndrome. So these are all various physical findings that we can see on examination. So this is just a glimpse. There are so many other anomalies, but the idea was to kind of get your interest into looking at the history and the examination. So now coming to the investigations. So I always think in terms of a library, a book, a page, and then the letters. And that's how I explain the genetic testing to the patients. So think about library as the nucleus and chromosomes here, and the book as a chromosome, and the pages and the lines as the DNA, and the letters as the single gene segment. So when you're explaining, it makes it easier that what happens is that there may be a spelling mistake, and this is what the single gene changes are. There can be spelling mistake, there can be extra material or less material. So chromosomal disorders, 25 to 30% of patients with developmental delay or multiple congenital anomalies, dysmorphic features, may have numerical problems, meaning extra or less number of chromosomes, or microdeletions and duplications. So as you can see over here, different chromosomes. And this is what we used to do, the G banding, the karyotype. So most frequently known chromosomal anomaly is Down syndrome, which is the 21 trisomy. And you see over here very typical clinodactyly. So these markings are closer than over here. There's excess space between first and second toe, and very typical facial features of Down syndrome with low set ears, epicanthal folds, and also macroglossia. So here you can see the non-disjunction or most common form of Down syndrome, which is the 3 copies, which is 21 trisomy, or 1421 translocation. So there is one big chromosome here, which is made up of 2 chromosomes actually, 14 and 21. So this is the Robertsonian translocation. So you've got, in essence, 3 copies of 21, 1, 2, and 3. So this is a rare form of mechanism, but we do see it. It's about 3 to 4% of Down syndrome have translocation, and there is no way to distinguish clinically between this form and this form. So you need to do a karyotype. If it is non-disjunction, that means the parents are going to have normal chromosomes. And with translocation, there will be an increased risk if the mother or father are carriers, especially if mother is a carrier. So you need to do parental chromosomes as well. So there are some well-known trisomies like trisomy 18. You see 3 over here, 3 copies, and trisomy 13. And again, these are big trisomies, and most of them don't do very well. But with all the assisted technologies, especially in the Western world, these children are surviving more, especially the trisomy 18 ones. Trisomy 13, they have very significant central cleft, as you can see over here. They can have cutis aplasia, and the trisomy 18, they can have rocker bottom feet. So now coming to genetic testing. So genetic testing is Pandora's box. So Pandora is in the Greek mythology. This was, she was a lady who opened this box and a lot of things came out. And they couldn't be put back. So this is what genetic testing is. There is so much information, and there's a gene for everything now. So you have to be careful about what you ask for. Sometimes you get information which you actually were not looking for. So incidental findings can also cause a lot of problems in health management issues. So this is the chromosomal microarray, which has become a standard for us. here for developmental delay assessment. And what we are looking for is deletions or duplications along the chromosomes, and which are not detectable by routine karyotyping. So like over here, you can see there are 3 copies, and over here, there's 1 copy only. So it's missing. So this is deletion and this is duplication, too much material. What are the results you may get? There may be normal, no copy number changes. There may be a deletion and duplication. It could be a known syndrome, and the diagnosis is then confirmed. It could be just a benign copy number variant and may not be very relevant. And this is what gives us, especially variants of unknown clinical significance. It gives us a lot of grief because a lot of pediatricians and family doctors, they may order and they may not understand the significance of the results. So we have to figure out, is this a benign variant or is this associated with the phenotype? So for that purpose, we will have to do parental testing as well. And if the parent is normal and has a change, then we usually will say most likely this is not relevant. But we have to study this further, especially the variants of unknown clinical significance. So here's a story of this boy who's a 5-year-old. He had global delays, autistic features, otherwise healthy, walking at 18 months, not able to draw a line, and only had a few words. As you can see, he has down slanting palpebral fissures. He has epicanthal folds. There's a philtrum which is smooth, and then a prominent chin. So we ordered a microarray, and this is how the report looks. So there can be oligonucleotide or single SNP type of array CGH, which is a comparative genomic hybridization. So that's for microarray. And it's very important to read the whole report very carefully. So it's talking about, it's positive. So in the chromosome 17, P is the short arm, petite arm. At the band 11, there are 3 copies. And so there is a duplication of an interstitial region within the cytogenetic band 17p11.2. And this duplication is a known duplication with Potocki-Lupski syndrome. So this is a rare syndrome, but it has been described before. So then what they did was look at the OMIM, which is online Mendelian inheritance in man. And I would encourage everyone to look at these free web databases if you have not seen. And then you can actually see what are the features of this condition. So dysmorphic features, mental retardation, there may be a behavioral phenotype, autistic features. And it is interesting because the same region, if there is deletion, it causes Smith-Magenis syndrome, which is another well-known neurobehavioral syndrome. But if there's duplication, it is Potocki-Lupski syndrome. So again, you need to go back to the databases to learn about the condition that is being reported. So they also requested the parental samples so that we can do the FISH studies to see where exactly the deletion or duplication is. So this is the Smith-Magenis syndrome I was talking about. So these children have brachycephaly. Their heads are kind of squashed together, low set ears. They have a very typical neurobehavioral phenotype. So they put objects in their ears, in their mouth, and they have very poor sleep. They can also be removing their nails, a lot of neurobehavioral symptoms. So this is due to 17p 11.2 deletion. So this is Smith-Magenis syndrome. So we talked about the chromosomes, thinking of books, and now we are going to the next part, which is the DNA, and that's the single gene disorders. So this is looking at the letters and seeing where the changes are. So sometimes I also tell people think about recipe. If you have to make a dish and if one of the ingredients is missing, that's another way to explain changes in the DNA, things which are missing your dish is not going to come out right. So the protein is not going to be made. So this is one of the well-known um, um, genetic disorders for developmental delay. About 5% of patients have this. This is Fragile X syndrome. And you see very typical features here of very prominent ears, slightly prominent jaw. The testes are large, and that sort of happens more in the puberty. So this is transmitted through the maternal line, and it's one of the triplet repeat disorders. So triplet repeat disorders have this phenomena which is called anticipation. With each successive generation, the repeats expand. So things like myotonic dystrophy, ataxias, Fragile X syndromes, a lot of neurological disorders have triplet repeat disorders. So this will not be picked up by microarray. Also, translocations will not be picked up by microarray. So you need to know the limitations, the advantages of each test that you're ordering. Coming to whole exome sequencing, or whole genome sequencing. So think about this as a whole genome. This is the slice of the apple is the whole exome sequencing. So exome sequencing is all the exons are basically taken together and the intronic parts are left. So we are basically sequencing the exons. That's the exome sequencing. So there are 6 billions of nucleotides in the genome, whole of our genome. Exome is only 1% of the genome. So although this is a great test and we are using it now very frequently, and I know in many parts of the world, people are using, even doing the next generation sequencing, they're actually using the basis exome sequencing, and then they just report the next generation sequencing for that particular disorder. But again, you need to know what are the limitations of whole exome sequencing as well. A lot of intronic deletions may be missed, intronic changes may be missed. So similar to microarray, you have to remember that American College of Medical Genetics has made 5 criteria classifying changes from normal to pathogenic and in between. So if it's positive, great, you have a diagnosis. If it's negative, it does not rule out a genetic diagnosis. It just tells you that so far we haven't found anything. And in between are variants of unknown clinical significance. These are the things which cause a lot of grief to all of us because we are not sure about it. Sometimes after a few years, there may be more reports than we can actually confirm the diagnosis. So these are the variants of unknown clinical significance. In addition, you get incidental findings that you were not looking for, and we have to consent the family to ask them if they want to know about incidental findings or not. So I'll give you a very interesting example. I saw this family, genetic testing in life and beyond, the importance of postmortem evaluation. So the main thing as geneticists, I feel we are like investigative, Sherlock Holmes kind of work that we do. So the story was that I was asked to see these twins. They were 17 years old, and their father had passed away following type A aortic dissection at very young age, 48. And there was a suspicion of Marfan syndrome, and please assess these brothers. So we actually requested for father's autopsy report, death summary, and tried to find if there was any genetic testing done. The autopsy said that the father had Marfanoid habitus, with the scoliosis, pectus carinatum, tall stature. And thankfully, the pathologist did take sample from the father's muscle, the autopsy muscle for DNA. So 2018, it was signed out, and then cardiovascular subspecialty report was signed in 2019. And what they found was that there was an aneurysm of descending thoracic aorta. There was dilated cardiomyopathy, and there were premature, severe medial degenerative changes and raising possibility of connective tissue disorder, such as Marfan syndrome or Ehlers-Danlos syndrome. So you can see here the aorta and also the dissection, and the heart, which is quite big. So there was a lot of back and forth because the pathologists, they took the DNA, but they did not know what to do with it. So they contacted my genetic counselor, and we then said, okay, this needs to go to CHIO, which is Ottawa lab. And we chose the panel Familial Thoracic Aortic Aneurysm and Dissection panel, which is the TAD panel. And these are the genes which are there in this panel. And we've kind of emphasized the SMAD3 gene. So we got the report back. This is from the father's results. It took a long time because, as I told you, nobody had done anything with the DNA, although they had taken it. And it showed that in the gene of SMAD3, there was a heterozygous, meaning one copy change, G2A, and it was classified as likely pathogenic. So when we get a genetic test, we look at if it has been described before. Are there any reports, publications about it? Is this change conserved through different species? That means it's an important amino acid. And what are the other predictions, in silico predictions for this variant? So these are the SIFT, polyphen, mutation taster. These are the three main ones that are used. And we also try and look this particular variant in genome aggregation database to see if it has been described before or not. So there were definitely reports of this particular change, and it was classified as pathogenic or likely pathogenic. We also found that it was listed in ClinVar database, which is our database which shows all the variations. So taking everything into consideration, they called it likely pathogenic, which I think was correct. So again, when you get a report, make sure what did the lab do? How did the lab come to this answer? Have they done in silico testing? Have they looked at the publications? So that's very important. So when I saw these two young men, they had hernia, they were striated, there was easy bruising. They had a very interesting features of camptodactyly, which is the bent finger. They had pectus carinatum, dental crowding, and there was enlarged aorta on one of these, one of the twins. This is the family tree. And you can see over here that this is the father who died with aortic dissection, scoliosis, and pectus, tall stature. And his mother had scoliosis and hernias and tall stature. So maybe she was also affected. So they were both found to be heterozygous for the familial variant. So both the boys had it as well. And then they came to see me. So remember, all those who have Marfanoid habitus do not have Marfan syndrome. Like you can see the typical Marfan syndrome and this lady with the eye findings and the stature and arachnodactyly. This is the picture of these two boys, and you can see over here that he had pectus. He also had pectus, and there was surgery on left foot, and he had an enlarged aorta. This young man also had other conditions, Kawasaki at 3 years, coronary artery fistula, brain astrocytoma. So he had quite a lot of other health issues as well. But look at the hands, there's arachnodactyly, and you can see the thumb sign, and you can see the finger here bent. You can see it better over here for both of them. They have the camptodactyly, the, the bent finger. So that's quite typical. And flat feet and pes cavus in one of them. So they had connective tissue features. So this is how do you arrive at a diagnosis? It's a complex method, but mainly it is being very diligent and going through every step very carefully, taking the history, making sure that you have a family history, examination, and then knowing which test to order, what are the limitations of test, and then coming to the final diagnosis. So they had hypertelorism, aortic aneurysm, bifid uvula, cleft palate, which was not in our patient. And this is the Louise-Dietz syndrome, which is like Marfan syndrome, but is different. So what is Louise-Dietz syndrome? So they can have arterial aneurysms in cerebral, thoracic, abdominal aorta, pectus excavatum, carinatum, so a lot of Marfanoid features, craniofacial features, bifid uvula, craniosynostosis, very translucent skin, easy bruising, scarring, and there may be incidence of eosinophilic esophagitis and gastritis. So this is the Louise-Dietz syndrome. So Dr. Dietz was the one who actually isolated Marfan syndrome gene. So this is a syndrome of altered cardiovascular, craniofacial, neurocognitive, and skeletal development caused by TGF-BR1 or TGF-BR2. These are the two genes. And this was described as the, it's like Marfan syndrome, but this is Louise-Dietz syndrome. And these are some of the features of patients who had Louise-Dietz syndrome. You see the aorta quite dilated, fingers, and you see the craniosynostosis, hypertelorism, bifid uvula over here. So you are seeing an overlap of different syndromes, Marfan syndrome, Ehlers-Danlos syndrome, Louise-Dietz syndrome, and Sprinz-Goldberg syndrome. So many of these syndromes have overlapping features. So if you see somebody with Marfan syndrome, it's not necessarily Marfan syndrome, it could be something else. So just to tell you a little bit about what this gene does, this is the SMAD family. It's also known as Mothers Against Decapentaplegic Homolog 3. So they give all these names. It's a protein at 15q, and it is implicated in transforming growth factor beta, TGF beta. And it's responsible for regulating certain cellular functions, including apoptosis, angiogenesis, and cell growth. So SMAD3 is over here. This is TGF beta, and a lot of cellular processes of cell growth are involved. So SMAD3 plays an important role in all these. And that's why you can see the connective tissue phenotype and the aortic dilatation. So another feature is osteoarthritis and aneurysms. Dissections actually can happen at smaller diameters than those that you see in Marfan syndrome. Arterial tortuosity is more prominent in head and neck vessels. So it's a very difficult syndrome diagnosis because once you diagnose it, you have to monitor it very carefully, looking for aneurysms. So these are just some of the clinical features that can be seen in different genetic etiologies for Louise-Dietz syndrome. The SMAD3, TGFB2, SMAD2, and you can see a lot of hernia in SMAD3 as well, pectus deformity, dural ectasia, arterial tortuosity is seen much more in TGFBR1. So there is a lot of overlap of features, as you can see with these genetic disorders. So it won't be possible for you to just go for single gene. That's why helpful to do the whole panel. So how do we manage these patients? We tell them not to do heavy weightlifting, avoid contact sports. And we really want them to have their blood pressures monitored carefully. And if there is aortic dilatation, then you ask them to use ARBs, angiotensin receptor blockade, and it has a theoretical effort on TGF beta pathway. But this is still being looked at, so that's the losartan. Echo has to be done yearly. You need to measure aortic roots carefully and basically do the whole body from root to pelvis, head and neck vessels imaging to look for tortuosity. And then go for surgical repair if there is, if the threshold is more. Now, this is an autosomal dominant condition like Marfan syndrome. 2/3 just happen on their own, spontaneous, and 1/3 are familial. Postmortem evaluation, that's why actually helped our family because the father did have autopsy done. You need to have collaboration with all the groups, cardiology, genetics, pathology, radiology, imaging. There is a lot of overlap of phenotype. And earlier diagnosis and screening can change the course. And there are neurotherapies coming up and psychosocial support. So as you can see, making a genetic diagnosis really has made a difference in this family. Lastly, I just want to bring to you that we are doing newborn screening for many disorders, such as cystic fibrosis, and newer drugs are being used for cystic fibrosis, for especially the Delta F variant. For SCID, severe combined immune deficiency, we have been using stem cell transplant. And lately, we have been screening for spinal muscular atrophy, and we are using nusinersen, which helps with the alternative splicing and converting the SMN1 to SMN2 gene. So there is very bright future for many of these patients who are affected with rare diseases and helping with their therapies. And this will also give us insight for common variants as well. So it's a very exciting time to be in medicine, I feel, for all of us, where, these were the conditions we would just be telling parents that there's nothing we can do. But now we can do something. So I'm going to be ending here with the pearls. And my pearls are, you need to really go back to the history. Family history is very important. Observation, like Oslerian way, recording, physical examination, very thorough physical examination, investigations. Need to know about which lab are you asking, what is their qualification, what have they done in this particular field, have they gone to the literature, and can you apply the genetic principles accurately? And like I mentioned, newborn screening is making a difference, and we are doing that for many metabolic disorders, but now also for genetic disorders. So thank you for listening, and we'll be happy to take any questions.
Thank you, Dr. Chitra, for such a wonderful lecture and telling us all about how to go about diagnosing an obscure disorder, and in a very story-like fashion, which I think would make it very interesting for the residents and other researchers to understand. I just want to ask you a few questions before we open the chat box questions. And the first one would be, how reliable is genetic testing in the prenatal scenario when you are going for a syndrome which is not very well established? So do you go for gene sequencing and then look at the data, or Is there any other way that you do it?
So prenatal testing is always, you have to be very cautious. So remember I showed you the ACMG different categories. So only if the mutation has been identified in the affected person, you can't start doing the testing first time in the prenatal scenario. You have to have a confirmed mutation in the family and know that that is a real mutation. And then, of course, you can use CVS or amnio and do the testing in that way. But
Yeah.
if it's a variant of unknown significance, the lab will not provide prenatal diagnosis because we are not sure.
Yes, thank you very much. And now that we have a genetic basis for almost every disease, which we encounter, and especially in relation to hereditary metabolic disorders, where we first used to do the biochemical parameters. You would like to see what is the excretion in urine of all these metabolites which are there. But now we have a genetic basis which is available to us for investigation. So, what is your approach? Do you still go through in the roundabout fashion doing all of the tests, or you straight away go for genetic testing?
So that's a very good question. I used to do a lot of metabolic testing, and as you know, it can be very expensive. It can be very tedious, finding the right lab. So we used to do a lot of metabolic testing, like measuring the metabolites, enzymes, and we still do that. But I go much more quickly now to exome sequencing or looking at the gene aspect because that is um, easier in some ways. But you have to sometimes go back to the biochemistry to confirm it. That is this a real change, or is this the variant of unknown significance you found? So I think they go hand in hand, but I am doing much more molecular testing.
So, does it turn out to be more expensive than doing the other metabolites? But it's certainly more sure, and even if you spend a little more money on this. And I think the tests are becoming cheaper now.
Yes, and what I used to do, when we did not have exome sequencing, I would be testing for this syndrome, that syndrome. So it would add up a lot of money anyway. So it's better to go for exome earlier. And the data is showing that just like you do the microarray, you actually are, it's going to become a first line exome, and then you think what else it could be.
Yeah.
So,
But I think it's extremely important to have a experienced geneticist, clinical geneticist around, so that they can pick and choose, what tests to pick up, or even what sequences to pick up for the testing. Because otherwise, you end up doing the whole thing and you don't know what you're getting.
yeah.
Because these days, people have got into the habit of sending samples for, whole genome sequencing or exome sequencing, and then trying to find out in retrospect whether they're finding anything. What do you think of this kind of approach?
I it is going to come, because the technology has become very advanced. But I do believe that there is room for clinicians and
Yes.
for somebody to think.
Yeah.
So I discourage some of our younger faculty and residents to just, mindlessly kind of doing the whole thing, but at least have some approach why you are doing it and think about it. So there are some chat questions. One is, how significant is NIPT in detecting chromosomal abnormalities prenatally? So it's about, I think, 70 to 80%, and mainly for the main trisomies. Again, you have to look at which labs you're doing and what's their comfort at doing it. So it's not 100%. Some labs will say more 80, 90%, some 80%. So basically for Down syndrome, trisomy 18, 13. How the genetic studies help in creating evidence in the polygenic and single gene disease. Kindly comment. So polygenic diseases are like the common diseases like diabetes, obesity, hypertension. And there are various studies that are happening in polygenic field as well. So they're more like additive, you have polymorphisms in a couple of genes and together when they come, but this is not single gene problem. So as we know for, some of the changes in different, like for dementia, again, they are helping, but they're not being used in routine care. So we have polygenic scores, but we are not using as much, like I'm not using in my clinical practice as much, but the data is coming, it will come.
Yeah, thank you. Another question is, these days another buzzword is precision medicine in terms of genetics, and now disorders are there for which treatments are available, or the treatments might become available with the genetic approach because you can create molecules, which can counter the defects. So how do you see this in future, that even in our common diseases, actually these days we're talking of precision medicine, say for tuberculosis also we're looking for genes which alter the metabolism. And I do remember your work initially about INH metabolism, and we are still talking about it, that some of the polymorphisms, they would metabolize this NAT2 and all those. So how is it a time to revisit now all these metabolic problems which are there for common diseases?
Yeah, so if you remember the Shakespeare's quote, one man's meat is another man's poison.
Yeah.
So I remember that. So remember that there is variability. And Sir Archibald Garrett, who was the father of metabolic medicine 100 years ago, said that there is chemical individuality. So we all, although 99.99% we are identical DNA wise, but that 0.01% we are different. So somebody will react differently. And when you were talking, I was thinking about, so I did a study on rapid and slow escalator status for INH. And
Yes.
we were finding toxicity with INH, with the liver toxicity. So clearly that was more of a biochemical. I'm sure now polymorphisms are known. So we actually in our university, we have pharmacogenomics. We have faculty in pharmacogenomics, and they are doing a lot of polymorphism studies for different antihypertensives and, some people reacting differently to different medications. So pharmacogenomics has come as a big way, and precision medicine is going to be here. That was one of the offshoots of the Human Genome Project.
Yeah.
So, we saw somebody would get penicillin anaphylaxis, and you give penicillin to so many people. And so
there might be a genetic basis to that, right?
yeah.
Yes, another question from Shivani Sankyan. How whole exome and clinical exome sequencing differ? How to decide which one to order or to prefer?
So I don't know if you mean whole genome, because clinical exome and whole exome is the same thing. Some labs have different depth of reading. So you need to know what is the depth of where they're going into the, when they're reporting, what's the depth. So you have to know that. But I don't think there's any difference in clinical exome and whole exome. It's the same thing, unless the labs are calling it clinical exome. I'm not sure. But whole genome is, of course, you're looking at every single nucleotide. And you can imagine the amount of data that is generated. It's not easy. There's a lot of ethics about genetics. What are we doing? What are we telling people? And then telling people right in the newborn period, your child is going to have something. One of the problems that happened was with Pompe disease. So they did newborn screening with Pompe disease and found that they found a variant, and the enzyme companies were very happy because they had a lot of patients. but this was a late onset variant, which did not have that much of phenotype. So with genetics, I want to caution everyone that you need to know about the ethical issues behind that. It's not like you're ordering sodium, potassium, calcium. It's not like that. You really have to think why you're doing it. What's the best way? Is it going to help, or is it going to cause more problem?
I think we've had a wonderful discussion, and there are so many points which are now cropping up and would make a basis for our future talks, especially the ethics related to genetics and other questions which are coming up about molecular genetics. So, and we are very happy to announce that Dr. Chitra will be available to us for a future series of lectures on genetics, which we will be announcing in the due course of time. But I think we would like to close for today. It was really wonderful, Chitra, to listen to your fine talk, and I think it's made my day, and perfectly fine to talk to you and listen to the wonderful thoughts and ideas that you have. Thank you very much. I would really thank you for joining us today.
Take care. All the best.
Yeah, thank you so much.
Thanks, Meenu.
Thank you.
Bye.
Thank you.
Bye.
Bye.